بسم الله الرحمن الرحيم. هنبتدي النهارده إن شاء الله مع مجموعة من البون تيومرز بتعمل لي chondroid matrix. هنقول عليها الchondroid forming tumors. الchondroid forming tumors دي هنقسمها زي ما احنا متعودين ل benign tumors و malignant tumors. النهارده موضوع المحاضرة دي هيكون على البيناين chondroid forming. عايزين نعرف بس مع بعضنا الكرايتيريا بتاعة الكارتليج، الهايلاين كارتليج. احنا عارفين الكارتليج معمول من ماتريكس وأوستروما وكوندروسايت. ماتريكس عندنا هنا بيكون أمفوفيليك وبيكون هايلاين، مفيش فيه فايبرس باندز، والكوندروسايتس بتبقى موجودة جوه لاكيوني، جوه سبيسز في الهايلاين كارتليج. الكوندروسايت بتبقى موجودة سينجلي، يعني كل لاكينة فيها only one cell. الكوندروسايت بتبقى ليها rounded well defined nucleus or lymphocyte-like nucleus and abundant eosinophilic cytoplasm. كل لاكيونة من دي فيها only one chondrocyte. لما بنلاقي إن في اللاكيونة more than one chondrocyte هنا بيبقى عندنا pathology and I have to define this. زي ما اتفقنا الchondrogenic lesions أو الchondrogenic tumors بنقسمها ل benign ومالجنانت. البيناين زي الأوستيوكوندروما، Enchondroma, Periosteal Chondroma, Chondroblastoma and Chondromyxoid fibroma. المالجنانت عندنا Chondrosarcoma الكونفنشنال تايب بتاعها، وبعدين عندنا subtypes أو varieties منها clear cell chondrosarcoma, dedifferentiated chondrosarcoma and mesenchymal chondrosarcoma. recently WHO عملت لنا classification بوجهة نظر مختلفة للchondroid forming tumors. عندنا برضو benign وmalignant. على to the left these are benign tumors, to the right these are the malignant tumor, and in between we have intermediate tumors. Two types of intermediate tumors. One intermediate in the sense that the tumor is locally aggressive, and other intermediate tumor in the sense that it can rarely metastasize. So let's start with benign tumors. We have osteochondroma, chondroma, enchondroma, periosteal chondroma, osteochondromatosis, subungual exostosis. These are Periosteal osteochondromatous proliferation and synovial chondromatosis. For the locally aggressive, we have chondromyxoid fibroma with liability for recurrence, and this new term used by the WHO, which differentiate or which include two categories in one category. When you have a benign tumor, a chondroma, and you can decide whether it is a cellular benign tumor or it is a grade 1 chondrosarcoma. So the WHO introduced this expression, atypical cartilaginous tumor / chondrosarcoma grade 1, because both of the categories are treated by the same way, by extensive curettage. So if you can decide, you don't have to, and just report atypical cartilaginous tumor / chondrosarcoma grade 1. This intermediate type, in the sense that it is rarely metastasizing, it is chondroblastoma. Malignant tumor, we have conventional chondrosarcoma grades 2 and 3, dedifferentiated chondrosarcoma, mesenchymal chondrosarcoma, and clear cell chondrosarcoma. Now, let's start with the first benign chondroid tumor, which is osteochondroma. Osteochondroma, a frequent benign tumor, previously considered as a developmental malformation. However, Recently, it is confirmed that it is a benign monoclonal tumor of cartilaginous origin. It is a benign cartilage-capped tumor that originates in the metaphysis or the region of apophysis, arises on the surface of bone, and it enlarges through the process of enchondral ossification. It occurs in two types or two clinical settings. It may be solitary lesion in 90% or more of cases, or it may be multiple lesion as a part of multiple hereditary enchondromatosis, which are represented by less than 10% of the lesions. Here, chondrocytes in the cap are the neoplastic element of the tumor, and they have a genetic mutation, inactivating mutation, affecting gene EXT1, EXT2, and EXT3, genes that are found in chromosome number 8 and number 11. Chondrocytes represent monoclonal cellular proliferation, therefore they are benign tumors, not developmental malformation, and they are the cartilage cells or the neoplastic component of the tumor, not the bone. This is a case of osteochondroma. It is the most common benign tumor, 90% solitary, 10% occur in heritable multiple exostosis. The lesion may be sessile or pedunculated, and male to female ratio is 1:1, with the age 80% of age of diagnosis at the first decade of life. Under the microscope, this is the cartilaginous cap covered by perichondrium, and the cartilaginous cap here near the inner side of it. Chondrocytes are arranged in columns exactly like what happens in epiphyseal cartilage. Then it becomes divided. Here is endosteal ossification, and these are bony trabeculae. This is the stalk of the tumor, bony trabeculae, separated by marrow spaces, and this is the cartilaginous cap. Radiology. Radiology is very important to differentiate osteochondroma from other mimics. So it arises on the surface of the bone, and this can occur in many other tumors. However, in osteochondroma, just this, the cortex and the medulla of the tumor, this is the tumor and this is the mother bone, you can find that the cortex and medulla of the tumor are continuous with that of the mother bone. So it is an indentation of the mother bone. The tumor is continuous by the cortex and medulla with the bone of origin. So it arises from the surface of the bone. Cortices of the lesion and underlying bone and the marrow cavities are in direct continuity with the mother bone. This is a very important point. The lesions point away from the nearest joint. This is the nearest joint, the knee joint, and this is an osteochondroma. It points away from the nearest joint. Why? This is because the traction caused or exerted on the tumor by the muscles and joints. So lesions point away from the nearest joint in reaction to forces exerted by muscles and tendons. The cartilaginous cap or the cartilaginous cover is bosselated. Here it is bosselated. It is bosselated with areas of calcification. The tumor may be sessile, here sessile with broad base, or pedunculated with narrow base and mushroom-like shape. Once more, this is the lower femur. This is an osteochondroma. This is the bony stalk, and this is the cartilaginous cap. And here is area of calcification. Osteochondroma is a relatively small, purely extraosseous tumor that is well circumscribed. Grossly, here is the cartilaginous cap, and here is the stalk of bone, ossified bone. The cartilaginous cap here is homogeneous and thicker in adults, or during development, the thickness of the cartilaginous cap becomes less and less. Still, in the adult life, it can be completely attenuated. What's very important is that if you see in adults the cartilaginous cap is thickened, this is a worrisome sign, and it can indicate malignant transformation. Under the microscope, here is the perichondrium, here is the cartilaginous cap, and here at the inner end or the inner side of the cap, here is endosteal ossification. And this is endosteal ossification with bony trabeculae forming this stalk separated by marrow space. So it starts at the physis and it migrates down the bone, and the growth stops by skeletal maturity. This is very important. May be multiple as part of hereditary multiple exostosis. The stalk, the cortex and medulla of the stalk are continuous with that of the cortex and medulla of the mother bone. This is very important. The hyaline cartilage, the cap made of hyaline cartilage, is covered by perichondrium, and it should be less than 1 centimeter thick in adults and show enchondral ossification. Chondrosarcoma, to differentiate it from chondrosarcoma, chondrosarcoma, especially if in the axial stream there is rapid growth of the cartilaginous cap, and is usually associated with pain without associated fractures. So if there is a history of recent increase in size with associated with pain, this is a worrisome sign, and it can indicate malignancy, especially if it is multiple exostosis. A differential diagnosis, most important differential diagnosis of osteochondroma is Periosteal osteosarcoma. These are proliferative osteochondromatous proliferation or Norris lesion and subungual exostosis, or are exotopic or tumors that are present on the surface of the bone. Now, for differential diagnosis, the first one is bizarre periosteal osteochondromatous proliferation or Norris lesion. Regardless the site, if you remember that Norris lesion occurs most frequently in the short bones of the hand and feet, while osteochondroma occurs most frequently on long bone. Norris lesion contain reactive fibrous tissue overlying the cellular cartilaginous cap that undergoes enchondral ossification. However, the underlying cortex is intact, and there is no continuity between the cortex medulla of the lesion and that of the mother bone. The lesion seems to be stuck on the outer surface of the cortex and not continuous with the medullary cavity of the mother bone. Second differential diagnosis is periosteal myositis ossificans. In myositis ossificans, when it arises on the surface of the bone, the cortex also is intact, and there is no continuity between the lesion and the underlying bone. And also periosteal myositis ossificans, it lacks the well-formed cap of hyaline cartilage. It has no hyaline cartilaginous cap. We have another lesion that is present on the surface of bone, but it is formed completely of lobules of cartilage. This is the surface or periosteal chondroma. It arises on intact cortex. Once more, there is no continuity between the lesion and the underlying bone, and it is composed of lobules of cartilage only without enchondral ossification. One of the most common differentials of osteochondroma is surface osteosarcoma, periosteal osteosarcoma. Also, periosteal osteosarcoma is anchored to the external surface of the cortex without continuity between it and the medullary cavity. Histologically, both can contain cartilaginous cap, but the cartilaginous cap in periosteal osteosarcoma is more cellular, more disorganized, although it can be with minimal cellularity, and it can go enchondral ossification. In periosteal osteosarcoma, we have a very important component of the tumor, which is the sheets of spindle-shaped malignant cells adjacent to the neoplastic bone, which is not the case in osteochondroma. Now, what about malignancy in osteochondroma? Malignancy in osteochondroma affects only the cartilaginous cap, so we are speaking about chondrosarcoma. It is more common when the lesion is multiple, and it can be suspected if we find recent increase in the size of the tumor with very thick cartilaginous cap and associated pain. These are the symptoms that make you suspect malignancy in a previous osteochondroma. So the finding of thick active cartilaginous cap in an exostosis in a skeletally mature individual, especially if the lesion has a history of recent growth, should alert the clinician and pathologist to the possibility of malignant transformation. Here is the cartilaginous cap, stellated, very thick, with areas of calcification. This is an example of multiple exostosis or multiple osteochondroma that one of them undergoes malignant transformation. This is the iliac bones. This is one osteochondroma. This is another one. This is another one. This is another one. But see this one. There is marked enlargement of the lesion. Here are the cartilaginous cap with extensive areas of calcification. So this is a CT scan of the pelvis of a 36-year-old man with known multiple exostosis. It reveals a large calcified mass in the wing of the ilium, which has been increasing in size. When this tumor was resected, here is the cartilaginous cap, ocellated outer cartilaginous cap, very thick cartilaginous cap with areas of calcification. So this is a transected specimen removed from the patient. Note that there is a thick cartilaginous cap on the surface and the extensive calcification. This white area is calcified cartilage within irregular ostellated lesion. Then the tumor under the microscope, you can notice that the cartilage here is highly cellular. Sometimes we can see two nuclei inside one lacunae, binucleated cells inside lacunae with some sort of pleomorphism and atypia. Is covered completely by perichondria. However, the cellularity is high with some sort of atypia. So there is, if you combine the clinical, the radiological, the gross, and the microscopic appearance of the lesion with the history of recent increase and history of multiple osteochondromas, you can reach diagnosis very easily. So this is a photograph of a cartilaginous cap of the specimen shown previously, the gross and the radiological. The cartilaginous cap is covered by a dense fibrous capsule, perichondrium, and the cartilage matrix is filled with crowded viable chondrocytes. هنبتدي بقى في تاني benign tumor, benign cartilage forming tumor, one of the most frequently encountered benign tumor, which is Enchondroma. Enchondroma is a benign cartilage tumor found in the medulla of of bones, especially the short bones of the hands and feet. Then come long bone other bones. So they are centered in the medulla, often of the tubular bone of the hands and feet. It may be solitary, or it may be part of multiple enchondromatosis. If multiple enchondromatosis occur predominantly in one side, unilateral, it is called Olier's disease. If bilateral, it is usually associated with spindle cell hemangioma, and it is called metaphysis syndrome, and it has increased risk of chondrosarcoma plus primary visceral neoplasm. Typically, Enchondroma is a solid hyaline matrix without myxoid degeneration. It is hypocellular with vague clusters of small cells with small chondrocytes with small single nuclei present in lacunae with lobular architecture and a peripheral rim of bone. The arcs are formed of fused lobule and separated lobules at the periphery surrounded by marrow. If enchondroma is multiple, or if it occurs in the hands and feet, it is usually hypercellular. So some sort of hypercellularity can be seen or frequently seen in enchondromas of the hand, feet, and in multiple enchondromatosis, sometimes with small foci of myxoid change, and this is not considered as malignant features. So it is allowed to have some sort of increased cellularity. Sometimes enchondroma may have sudden occurrence of high-grade sarcoma, which is called dedifferentiated tumor. This dedifferentiated high-grade sarcoma may be chondrosarcoma or other sarcoma. So in enchondroma, just be careful to sample your specimen well so as not to miss dedifferentiated area. The most important differential diagnosis in case of enchondroma is chondrosarcoma. Good clues to differentiate is the clinical picture of pain or recent increased growth, radiological features of infiltration, macroscopic appearance of myxoid change, and microscopic appearance. The most important microscopic clue of malignancy is permeation, plus the positivity of chondrosarcoma to ERG immune. So enchondromas account for 3 to 10% of all bone tumors, so it is a frequent tumor. Usually present in the third and fourth decades, rare in children and in elders. Almost 90% are solitary, 10% are multiple, either Ollier or Metaphysis syndrome. It predominates in the distal appendicular skeleton, hands and feet, or proximal bones. If it is present in the axial skeleton, if you see enchondroma in the axial skeleton, consider chondrosarcoma, even if the morphology, if the microscopic appearance is quite benign. Enchondroma is usually asymptomatic, frequently detected as incidental finding. Solitary enchondromas can be treated only by follow-up. Tumors with questionable radiologic finding should be considered as chondrosarcoma and curated to be sure it is. Now, what about the radiology? It is the typical radiology of benign chondroid tumor. The tumor is spherical or oblong with well-defined borders and dots of calcification. The radiodensities with ringed speckle pattern, arcs and rings with rounded borders or arcs and rings. In children, enchondromas tend to be larger and show endosteal scalloping. Here's a large enchondroma. It causes indentation of the endosteum, which is called endosteal scalloping, indentation of the endosteum, which is called endosteal scalloping. Sometimes we can see mineralization. Macroscopic size ranges between 3 and 5 centimeters. Some are large enough to produce visible deformity. The lobules of cartilage are these bluish areas. The whitish areas denote areas of calcification. Now, under the microscope, I have a very well defined cartilaginous lobule with perichondrial ossification at the periphery, sometimes perichondrial ossification and enchondral ossification in the center of the lobule. So the lobules appear very well circumscribed by surrounding bone formation. So microscopically, it is composed of cartilaginous nodules. These are the cartilaginous nodules, well circumscribed with no infiltration of trabecular bone. Matrix is hyaline. Exoid matrix is uncommon. Enchondromas in the small bones of the hands and feet or in multiple enchondromatosis may demonstrate hypercellularity and some sort of cytologic atypia. Myxoid change and chondrocyte necrosis are not found or should not be found. If we find myxoid change or chondrocyte necrosis, consider chondrosarcoma. This is an enchondroma in the small bone of the hand, of the finger. See that the border is very well circumscribed. Very well circumscribed by enchondral ossification at the periphery, the peripheral rim of bone. So lobules of cartilage can undergo peripheral enchondral ossification. Peripheral enchondral ossification. Calcification of the osteoid correlates with the characteristic ring calcification of enchondroma seen in. This is an enchondroma, lobulated outer surface. It has very sharp borders between it and the host bone. This is an enchondroma with poor cellularity. Chondrocytes are found singly inside lacunae with no pleomorphism or atypia. So this is the classic form of this hypercellular chondroma with some sort of atypia and binucleated cells inside lacunae. Some lacunae contain 3 cells. This can simulate chondrosarcoma. However, knowing that this tumor occurs in the small bone of the hand, or if you know that this is a case of multiple enchondromatosis, this is allowed. You can see this normally without being a chondrosarcoma. So enchondromas of the small bone of the hands and feet often demonstrate increased cellularity and some sort of nucleus. This is a case of multiple enchondromatosis with the lobules of neoplastic cartilage reaching near to the joint. Once more, this is an enchondroma as part of multiple enchondromatosis. There is lobules of chondroid with marked hypercellularity, and what's more important is that myxoid change. This is allowed as regards multiple enchondromatosis. So the lobular and cellular appearance of the cartilaginous nodule in enchondromatosis, these lesions usually exhibit more cellularity than seen in solitary. This is a high power with myxoid change, pleomorphism, hyperchromatism, atypia. However, knowing that it is multiple enchondromatosis, this is not considered malignancy. So the higher power view shows myxoid appearance of the tumor with crowded stellate cell. However, still it is a benign. How to section a case of enchondroma. لما نجيلنا حالة enchondroma, please consider the following. If you have a curettage, if you receive the specimen as fragments, please process the whole tumor so as not to miss the focus of the differentiation. If you have a resection, take a section from each 1 centimeter. Concentrate on the non-calcified region because calcification will mask the pathology behind. Submit the closest bone and soft tissue margin and take your sample from the interface between the tumor and surrounding bone to detect any infiltration. So at the margin you can detect the infiltration, which make the diagnosis be chondrosarcoma. Take care to process some tumor without calcification for further molecular. What's the differential diagnosis of enchondroma? The most frequent tumor that may be mistaken or misdiagnosed as enchondroma is low-grade chondrosarcoma. In low-grade chondrosarcoma, it goes with infiltrative pattern. This may be the only clue to diagnose chondrosarcoma. Chondrosarcoma have greater degree of cellularity and nuclear atypia. At the molecular level, chondrosarcoma has increased expression of 2 microRNA 181A and 138. This is expressed in low-grade chondrosarcoma, not in enchondroma. The treatment of both low-grade chondrosarcoma and enchondroma, or atypical enchondroma, is the same with extensive curettage. So it's not so difficult, or it is not a problem to misdiagnose the two because both have the same treatment. Both are treated by aggressive curettage. In the latest WHO classification, it introduced the term atypical cartilaginous tumor / chondrosarcoma grade 1. So if you can decide whether the tumor is enchondroma or low-grade chondrosarcoma, you can make in your report atypical cartilaginous tumor / chondrosarcoma grade 1, and both will be treated by the same line of treatment. Recently, ERG immune stain showed to be positive in 85% of cases of chondrosarcoma, so it can support your diagnosis of sarcoma. One other differential diagnosis is chondromyxoid fibroma. In chondromyxoid fibroma, I have myxoid and fibrous tissue, which is not the case in the case of Enchondroma. In Enchondroma, we have only lobules of hyaline cartilage. However, chondromyxoid fibroma, it lacks the well-formed hyaline cartilage. The site and radiology of chondromyxoid fibroma are very characteristic in the metaphysis of long bone with the long axis parallel to the long axis of bone. This is the typical radiology of chondromyxoid. البيناين تيومر الثالث اللي هناخده بالنسبة للكوندرويد فورمينج تيومر هو رير تيومر اسمه Periosteal Chondroma. البريوستيال كوندروما بيبقى سيرفيس تيومر، ادي التيومر اهو سيرفيس تيومر معمول من benign cartilage. It is not infiltrating into the cortex. No, it is just above the bone. It is a tumor that is completely above the bone. So the differential diagnosis of periosteal chondroma includes all tumors that are found on the surface of the bone. So this tumor is a benign chondroid tumor made up of lobules of cartilage. It is present in the subperiosteum. It is present on the surface of the bone, causing indentation or what's called saucerization of the surface of the bone without invasion. So it is a well-circumscribed small chondroid lesion on the surface of the bone, mostly the tubular bone, rare in hands and feet. It causes scalloping, indentation, or scalloping of the surface of the bone, saucerization, but it is not infiltrate. This is the radiology. This is the gross picture. Lobules of cartilage present on the surface of the bone, causing indentation without infiltration. Here is Periosteal Chondroma. Here is under the microscope. The tumor is formed of chondroid matrix with chondrocytes inside lacunae with some degree of increased cellularity. Under the microscope, this is the hyaline matrix. These are the chondrocytes inside lacunae with some degree of pleomorphism. So the nucleoplastic matrix is hypo to moderately cellular. Chondrocytes are bland. May demonstrate mild to moderate atypia in the form of nuclear enlargement, prominent nucleoli, and binucleation. Matrix is composed of hyaline cartilage, may show focal areas of. What's important about periosteal chondroma is the differential diagnosis. You have to differentiate this tumor, this benign tumor, from other benign and malignant tumors that occur on the surface of bone. First one is Periosteal Chondrosarcoma. As you know, it is somewhat difficult to differentiate benign chondroma from chondrosarcoma. If you can rely only on the cellularity and pleomorphism, it is that clue only. So in Periosteal Chondrosarcoma may be somewhat more cellular, somewhat more pleomorphic, but you can differentiate using ESR. Second is periosteal osteosarcoma. Periosteal osteosarcoma, it demonstrates more cytologic atypia, sure with the presence of neoplastic bone. These are periosteal osteochondromatous proliferation. It has a cartilaginous cap with fibrous tissue and enchondral ossification, which is not the case in periosteal chondroma, which is formed only of lobules of cartilage without bone. So bizarre periosteal osteochondromatous proliferation is composed of reactive fibrous tissue with cellular cartilaginous cap which undergoes enchondral ossification. The third is, or the fourth, is periosteal chondromyxoid fibroma. In periosteal chondromyxoid fibroma, we see myxoid areas and fibrous areas. However, in periosteal chondroma, it is formed only of lobules of cartilage. Myxoid change may be found focally, but we can see wide areas of myxoid or fibroid tissue. Periosteal osteosarcoma, also a surface lesion or a surface malignant tumor that may contain cartilaginous cap. The cartilaginous cap is formed of disorganized cartilage and may demonstrate enchondral ossification. In addition, in periosteal osteosarcoma, we have the spindle-shaped component of the tumor together with the neoplastic. Fourth benign tumor, benign cartilaginous tumor, is a very peculiar tumor. This peculiar tumor is categorized by the WHO as an intermediate tumor in the sense that it can rarely metastasize. This tumor is chondroblastoma. Chondroblastoma is a specific type of tumor with very localized sites inside the bone, and it occurs in young age before bone maturity. So the lesion occurs in the epiphysis in immature skeleton. This is very peculiar. To differentiate this epiphyseal tumor from other tumors that may arise in the epiphysis, namely giant cell tumor, which occurs in skeletally mature skeleton, and clear cell chondrosarcoma that may occur in elder age, and to differentiate it from aneurysmal bone cyst, because this tumor may cause secondary aneurysmal bone cyst component. So it is important to differentiate the tumor as regards its site from other tumors that are epiphyseal. Now, chondroblastoma is a rare benign tumor derived from chondroblast. It is found in the epiphysis of long bone, usually lower extremity. The most common site is the distal femur, then the proximal femur, then the proximal humerus, and the proximal tibia. This tumor has a specific mutation in the gene H3F3A, which is found in most cases, so we can use immune histochemical stain called H3K36M. This can differentiate the tumor from giant cell tumor if we can differentiate histologically. So it is centered in the epiphysis of long bone, may give rise to benign metastasis. This is what is peculiar about this tumor. Under the microscope, we find that chondroblastoma, you can recognize four very important components. The first is the polygonal cells with well-defined cytoplasm and oval nuclei that may be grouped in a coffee bean appearance. The tumor is generally bland, but random atypia mitosis are present, but not numerous and not abnormal mitosis. I have areas of chondroid. This chondroid is characteristically pink. We call it pink chondroid. Chondroid here is pink in color. We have a peculiar type of calcification. It is a pericellular calcification called chicken wire appearance. This is very characteristic to this type of tumor. There is no intercellular matrix except for the chondroid. Coagulative necrosis, and sometimes we have a mix. So this is the first component. The tumor is cellular. These cells are the chondroplasts. Chondroplasts are found in sheets like that. We have osteoclast-like giant cells. We have chondroid, which appears pink chondroid, cartilage matrix of chondroblastoma. Typically, these are the chondroplasts, osteoclast-like giant cells. We have the areas of chondroid, and see this type of calcification. This type of calcification encircles each cell individually. This is called chicken wire calcification. These are the chondroplasts with distinct cell borders, eccentric nuclei, and some nuclei are grooved and appear like coffee beans. This is the peculiar type of calcification, pericellular calcification surrounding each cell. This is the chicken wire calcification. This is the osteoclast type giant cell. Differentiation of this tumor. This tumor have chondroblasts. Chondroblasts are bimental, S100 and SOX9 positive. May be positive for cytokeratin, smooth muscle actin, and epithelial membrane action. Differential diagnosis as regards the site is giant cell tumor, but giant cell tumor occurs in a skeletally mature skeleton. Aneurysmal bone cyst, as I have just said, this tumor may contain foci of secondary aneurysmal bone cyst. Other differential diagnosis is the chondromyxoid fibroma. However, the site chondromyxoid fibroma occur in the metaphysis of long bone and is eccentric, and cytology, which in chondromyxoid fibroma I have chondroid, myxoid, and fibrous areas. However, in chondroblastoma it does not contain this mixture. Also, as regards size, we have to differentiate it from clear cell chondrosarcoma. Clear cell chondrosarcoma is a chondrosarcoma with areas of clear cells due to intracytoplasmic glycogen. In chondrosarcoma also, which is very important, is invasion, entrapment of the host bone inside the tumor. Also, in the differential diagnosis, we have osteosarcoma. Sometimes the pink chondroid resembles osteoid, and we misdiagnose it as osteosarcoma. However, in osteosarcoma, it is invasive with pleomorphic cells and lacy mineralization. Mineralization of osteoid here is lacy mineralization, not the honeycomb peculiar type in So chondroblastoma, it occurs in age of 10 to 25, skeletally immature individual. It is treated by curettage with a recurrence rate of 14 to 18. Benign pulmonary metastasis from histologically benign chondroblastoma, although uncommon, but it can occur. Imaging, it is intramedullary, well-defined tumor with a sclerotic margin, radiolucent with internal calcification, and it is an epiphyseal tumor completely included within the epiphysis. Macroscopic, nothing specific, it is gritty, grayish-white, hemorrhagic with cystic areas are common. This is secondary aneurysmal bone cyst. So, if you see aneurysmal bone cyst in a skeletally immature epiphyseal region, please search for chondroblastoma because aneurysmal bone cyst may be a secondary change. Microscopically, we have the tumor is densely cellular, composed of a mixture of mononuclear chondroblast, multinucleated osteoclast-type giant cell. Chondroblasts grow in sheath. Matrix is generally consists of poorly formed hyaline cartilage, pink cartilage, and chicken wire calcification. The top differential diagnosis: chondromyxoid fibroma, site and cytology, aneurysmal bone cyst, may be secondary aneurysmal bone cyst with other areas of the tumor showing the full picture of chondroblastoma, clear cell chondrosarcoma, here is we can see invasion, giant cell tumor, epiphyseal in a skeletally mature skeleton, chondroblastoma like osteosarcoma. Here we have the other features, the pattern of calcification in chondroblastoma, and in osteosarcoma we must see invasion. رقم 5 بقى والتيومر الأخير من البناين chondroid forming tumors is chondromyxoid fibroma. Chondromyxoid fibroma is a rare tumor and it has also, as chondroblastoma, specific criteria that may facilitate the diagnosis. So it is a very rare benign bone neoplasm, most often discovered during patient second and third decade. So as the age incidence in the second and third decade. Now this tumor is metaphyseal. It is a metaphyseal tumor, usually in the region of the knee, lower femur and upper tibia. It is lobulated, well circumscribed, metaphyseal and eccentric. These are very characteristic radiological pictures or radiological features to differentiate or to help in the differentiation of chondromyxoid fibroma from other benign chondroid forming tumors. The lesion usually occurs eccentrically in the metaphysis of the lower femur and upper tibia, or in the short bones of the foot. Once more, the radiological features are very characteristic: metaphyseal, eccentric, with the long axis of the tumor parallel to that of the bone, the mother bone. The long axis of this tumor, it is parallel to that of the long bone. It is lobulated, well-formed lobule, and eccentric. Osteolytic lesion. Here is the gross picture. The tumor is evidently lobulated, eccentric, with the long axis parallel to that of the long axis of the bone. So in imaging we have eccentric, radiolucent, well circumscribed margins, multilobulated lesion in the metaphysis, long axis of the tumor parallel to that of the long axis of bone. May contain foci of calcification. Macroscopic, the size ranges between 1 and 10 centimeters. It is well circumscribed and very evidently lobulated tumor. The microscopic picture of the tumor with a low power is evidently lobulated. We have definite lobules. The lobules are formed of chondromyxoid lobules, and this is the fibrous stroma. So I have lobules, well-defined lobules. The lobules are formed of myxoid and chondroid tissue, and in between the lobules we have fibrous bands or fibrous septa with giant cells, osteoclast-like giant cells. Sometimes we have cystic spaces with secondary aneurysmal bone cyst-like lesion. Sometimes in the fibrous area we have blood vessels with branching staghorn pattern. So at lower power, chondromyxoid fibroma has a definite lobular growth pattern. Higher power, at the periphery of the lobules, we have increased density of cells. The center of the lobules contain myxoid cells. The cellularity at the periphery of the lobules are more dense than in the center. This is the fibrous septa with giant cells, and sometimes we have cystic spaces contain blood. Lobules of chondromyxoid fibroma have increased cellularity at the periphery with loose myxoid stroma at the higher power of the center of the lobule. I have spindle or triangular stellate cell with cytoplasmic eosinophilic cytoplasm with cytoplasmic extension. So the cells of chondromyxoid fibroma within the lobule or in the center of the lobule have spindle shape, stellate cytoplasm, small round nuclei to polygonal nuclei with fine chromatin and eosinophilic cytoplasmic extensions. Sometimes we have some bizarre cells like that with large nuclei, with large pleomorphic nuclei. However, if you see these cells with large nuclei, they have also increased amount of cytoplasm, so the nucleocytoplasmic ratio is not increased. These are some sort of degenerated cells. So occasional cells may show nuclear atypia with large nuclei and smudgy chromatin. Cytoplasm is abundant, so the nucleocytoplasmic ratio is not increased, not a sign of malignancy. So in the microscopic appearance, we have number one, well-defined lobule. The lobules are composed of relatively hypocellular chondroid or chondromyxoid tissue that is more cellular at the periphery, often vascular. The tumor is vascular with vessels having branching staghorn pattern. Regarding the immune histochemistry of the tumor, cells in the cartilaginous areas stain for S100. This is normal, this is large. The peripheral cells or cells at the periphery of the lobules are S100 negative. However, they are muscle specific and smooth muscle actin positive. So they are myofibroblasts. Another peculiar feature in chondromyxoid fibroma is that the matrix of chondromyxoid fibroma contains 4 types of collagen. Collagen type 1, 2, 3, and 6. This finding is peculiar for chondromyxoid fibroma, and it is not found in any other benign cartilaginous tumor, benign or malignant. It's not the case in chondroblastoma, osteochondroma, enchondroma, or chondrosarcoma. So, chondromyxoid fibroma is the only chondroid tumor that has 4 types of. Another rare type of the rare chondromyxoid fibroma, it is a tumor formed of fibrous and myxoid tissue without chondroid and without lobulation. So this may be considered as a type of chondromyxoid fibroma called fibromyxoma, without chondroid and without evident lobulation. Differential diagnosis of chondromyxoid fibroma include chondroblastoma, enchondroma, fibromyxoma, low-grade chondrosarcoma, chondromyxoid fibroma like osteosarcoma. Let's consider each one of them. Chondroblastoma. If you remember, chondroblastoma is an epiphyseal tumor in a skeletally immature patient. This is not the case in chondromyxoid fibroma. Chondroblastoma contains the 4 elements: chondroblast, giant cells, pink chondroid, and chicken wire calcification. Chondromyxoid fibroma is typically lobulated. Unlike chondroblastoma, it contains myxoid tissue and it contains lobules that the cells are more condensed at the periphery. This is not found in chondroblastoma. Plus, radiologically, both lesions are completely different. Enchondroma is formed only of lobules of cartilage without myxoid and without fibrous component. In enchondroma, we have enchondral ossification at the periphery. This is not found in chondromyxoid fibroma. Fibromyxoma does not contain chondroid and is not lobulated. Low-grade chondrosarcoma, especially in grade 2 with myxoid changes. In chondrosarcoma, what's very important is number 1, the radiology, and under the microscope we have infiltrative tumors. There is entrapment of host bone inside the chondroid lesion. Chondromyxoid fibroma like osteosarcoma. Sometimes osteosarcoma and chondroblastic osteosarcoma contain area of chondroid and myxoid. However, in osteosarcoma, we should find osteoid, neoplastic osteoid, and there is evident infiltration. So these are the main differentiating points between chondromyxoid fibroma and other lesions. Sometimes the septa in chondromyxoid fibroma contain vascular spaces and is secondary aneurysmal bone cyst. However, chondroid lobules are characteristic of chondromyxoid fibroma. To differentiate it between it and chondroblastoma, in chondroblastoma some foci may be similar, but the size and the presence of other features, chicken wire calcification, help in the differential diagnosis. In enchondroma, it is composed of well-formed hyaline cartilage. Nodules of mature appearing hyaline cartilage is not found in chondromyxoid fibroma. Cartilage undergoes enchondral ossification in enchondroma, however, this is rare in chondromyxoid fibroma. To differentiate chondromyxoid fibroma from low-grade chondrosarcoma, especially type grade 2 with myxoid stroma. Age is different. In chondrosarcoma, chondrosarcoma, age is more. And chondrosarcoma lacks the lobulated architecture seen in chondromyxoid fibroma. It is less cellular with fewer blood vessels. It shows chondrosarcoma shows infiltrative growth pattern. This is very, very important, together with the radiological feature that demonstrates aggressive tumor with permeative advancing age. This is chondromyxoid fibroma like osteosarcoma. It is an osteosarcoma. Here, chondroid areas with myxoid appearance. Search in this tumor for bone formation. We don't have lobulation, such as occur in chondromyxoid fibroma. The tumor grows in a sheet-like pattern together with infiltrative borders and osteoid formation. By the end, clinically relevant pathologic features. Think of chondromyxoid fibroma when eccentrically located, well-defined metaphyseal lytic tumor is seen in a skeletally mature individual. Important pathologic features. Margins of the growth are well defined. At low power architecture, it is distinctly lobulated, composed of chondroid areas with myxoid and fibrous tissue. Fibrous areas often contain branching blood vessels that are hemangiopericytoma-like in appearance. Pseudomalignant features may be present. Thank you. Thank you very much.